there's a venous filling phase. There's a relaxation phase. There's an arterial venous phase on the right side that has to pump and fill the left side. And then there's a heart rate that also will control the amount of cardiac output per minute produced. So there's multiple components to it. So if any part of this component is an issue, if you're too fast, your heart rate is too fast, you're too slow, your LV is too thick, your LV is obstructed, all these things will cause heart failure. Your venous return is too much, you have chronic renal failure or liver cirrhosis, etc. All these things eventually will cause heart failure. Make sense? Okay? So the end stage is you want the cardiac output, but there's a lot of components reaching that cardiac output, okay? To make sure you have enough perfusion to your organs. So, the most common cause of heart failure is coronary artery disease. And it's not usually acute ACS, it's usually microvascular ischemia. People have diabetes, hypertension, dyslipidemia, they usually have, but not the big coronary arteries clog off, it's a small tributary arteries that clog off, and then eventually they develop heart failure over time. So they'll worsen their cardiac output, etc. And sometimes they'll come in with frank ischemia, obviously. A lot of them will come in with ACS, STEMI, and STEMIs, and they'll have significant coronary obstruction, and they'll worsen their cardiac output immediately. So atherosclerosis is the most common reason, and most patients have it who have heart failure. So you get thickened myocardium, worse diastole, worse ejection fraction, so worse filling, worse ejection, so eventually. The second most common reason is cardiomyopathies. Mostly it's, can happen due to viral infections, but mostly it's idiopathic. We don't know why, we think it's genetic. And then third common cause is valvular heart disease. So today we still see a lot of rheumatic heart disease. So mitral stenosis, mitral regurg. Elder patients with aortic stenosis, we see that as well. Bicuspid aortic valve, all these things will cause heart failure. Pericardial disease not as common. Pulmonary disease, like we talked about, is also a common cause of heart failure. And just for BNP is a pretty good marker for heart failure. Good initial peptide. It's not definitive, but a BNP is less like a negative BNP is almost definitively rules out heart failure. So it's pretty good, and you can use it to monitor disease. If the BNP is going up, then it's just the heart failure getting worse. And the BNP is reflected with the left atrial. So if basically it reflects your venous filling more so. If your veins are full of blood, the veins have ability to distend and contract just like arteries. The left atrium will start to dilate. There's a lot of pressure there, and then the higher the BNP, it's just there's more pressure in your venous system. Okay, does that make sense? All right. So how does your heart compensate for impaired output or impaired perfusion? Well, it does things. It does things by increases your stroke volume, which is increased the amount of blood it ejects per second. And then what does your body also do? Your body systemically increases vascular resistance to increase perfusion to the organs that carry the blood. And this all leads to cardiac hypertrophy. So the LV thickens, and the vessels become chronically calcified because of that. So how do we classify heart failure? Well, there's a lot of classifications. You can classify based on what I told you. Forward, heart failure, backward, right-sided, left-sided, acute, chronic. There's many ways. But mostly what you know now you'll see is HFpEF and a heart failure with preserved ejection fraction. These are the big ways of differentiate them, as your heart failure with normal ejection fraction or your heart failure with impaired ejection fraction. Okay, this is what you'll see in hospitals. And the treatments actually vary for these two types. They obviously overlap. People with heart failure with decreased ejection fraction will almost always have diastolic dysfunction, and they will have impaired dilatation as well. So what precipitates heart failure? This is most what we care about because it's a chronic disease, like I say. Rarely do we acutely diagnose heart failure, but sometimes you do. Someone will come in and they've never been seen before. They come in lower limb edema, shortness of breath, and you diagnose heart failure. Most people come in with exacerbations of chronic disease. So what exacerbates chronic disease is usually what causes the disease. That's essentially what it is. But for chronic diseases, for the most part, the most common cause, like seizures, like asthma, like non-compliance. So like I said, these patients are usually will go into volume overloaded states, so they're sensitive to volume. So if they're drinking too much fluids, or they're not taking their medication that prevents heart failure, they're going to come in. This is usually what they come in. They're not taking their Lasix, They're not controlling their blood pressure. They're taking too much fluids. They're taking too much salt. They're coming in heart failure. And then the second most common cause is ischemia. Common. They come in, they have ischemia, they'll get worsening heart failure. Okay. And then any sort of physiological stress, because it's a chronic compensated state. Heart failure is a compensation state, right? So if you stress these patients, if you give them an infection, right? Give them sepsis, they're gonna develop heart failure. And then the other common things is arrhythmias. If they go into AFib, a flutter suddenly, they won't tolerate it because they need that atrial kick. So arrhythmias are often precipitants in these patients. But then anything else can, anemia, pregnancy, thyroid disease, endocrinological disease, anything that will stress the heart that's compensated will make them go into acute heart failure exacerbations, all right? But remember, the most common cause is non-compliance, which is either medication or over intake of fluids. Make sense? So the history is important, right? For these patients with chronic heart failure, it's like, I didn't have symptoms of heart failure. You want to make sure it's heart failure. Remember, like we talked about the asthma talk? Like people often confuse asthma with heart failure. And then do they have ischemic symptoms? That's important. Have they had any previous cardiac instrumentation? Have they had any stents? Do they have any valve change? That's important. Have they had any echoes? What medication they're on? Are they compliant? These are all important factors. And then all these other signs of heart failure, which is like P&D, orthopnea, lower limb edema, etc. Okay. Most patients come in heart failure. They come in two types of them. I think there's hypertensive and hypotensive part. Mostly are hypertensive patients, and those usually do well. We'll talk about hypertension more specifically. They come in with wheezes and crackles. They may have JVP distension. JVP is not a useful test. Most people can't agree. If you ask two cardiologists, is the JVP elevated? Most likely they'll disagree. So it's not a very, it's too subjective. It's not objective. So it's not a good test. The other objective tests we have are like BMPs, chest X-rays, echocardiography is more objective. These are things that are more useful. We can hear. Obviously, the reason we ask you to listen to people's hearts and people's heart failure, not because we care about the third heart sound or anything like that, because most people are not good at doing that. But more, you're going to listen for valvular heart disease. They have aortic stenosis, mitral regurg. These are important findings. But mostly now we've replaced that with echo. Most people in the emergency department now will do echocardiography because they're trained to do it. It's not complicated, and they can see physically the heart itself and see if there's something wrong with the valves, if there's something wrong with the pericardium, if there's something wrong with the ejection fraction itself. Okay. So we don't have specific ultrasound findings that suggest pulmonary edema. We have specific findings for echo itself. So chest X-ray obviously is helpful because we can see chronic findings of heart failure. Cardiac enlargement, RV distension, and you see acute findings of pulmonary edema, which is venous congestion, back wing sign, etc. You can see pleural effusion, fluid in the fissure, all these signs that acute and chronic heart failure. CBC, is only useful if you think about exacerbations of heart failure, such as anemia or infection. That's kind of where it's useful. Metabolic profiles are useful because people sometimes say the patient has heart failure, but it's not. He has pulmonary edema, but it's not from heart failure. It's from renal failure. You'll see people with need dialysis. He's coming acute and chronic renal failure or acute renal failure, and he's dyspneic and has a B-line and everything, but it's not. He's hard to find. It's just that his kidneys have stopped working. Okay, so that's really where the renal profile comes in. Cardiac biomarkers, again, important, which basically are two things at this point, the BNP and troponins. Troponin, obviously, for ischemia is a big deal. Just remember, a lot of these patients will have baseline high troponin. They're not going to, especially if they have chronic cardiac disease, they will chronically leak troponin, because especially the high sensitivity troponin, if you run marathon and you measure your troponin, it's all going to be high. So you have to understand that the troponin doesn't necessarily mean ischemia. Does that make sense? Yeah? If you're in septic shock and I put you on vasopressors, your troponin's going to be high because there's a lot of stress on your heart. If you have heat stroke and you have metabolic derangements, your troponin's going to be high. So you have to understand and contextualize troponin. The BNP are very useful for acute heart failure exacerbation, but it's not available. Some places don't have it available, but it's useful. ECGs are useful because they're both diagnostic and prognostic, because it can tell you for ischemia, you need an ECG, right? If they're having STEMI and STEMI ischemic changes, or if they have like conduction abnormality, they have very bradycardic, called heart failure, or they have LVH, signs of chronic remodeling of the heart. So that's why the ECGs are useful for acute and chronic finding. So goals. How do we treat heart failure? Well, we try to reverse underlying pathophysiology. So understand what the baseline is, because somebody who has severe end-stage cardiomyopathy, who has like an ejection fraction of 15 as minimal function, you're not going to get him to walking and running across the room. He's not going to. The best you're going to get to is back to his baseline. You have to understand how what their baseline is. Then find out what the precipitant is. If his precipitant is ischemia, then you want to try to reverse their ischemia. If his precipitant is sepsis, then you want to fix it. If his precipitant is GI bleeding, then you want to give him blood, etc. So you have to understand the precipitant. And then they come in the two types. The most common type, which is hypertensive, and then the hypertensive. We'll talk about them specifically. For the most common, which is the hypertensive heart failure patient, we generally treat the symptoms. If they're hypoxic, we give them oxygen. If they're not hypoxic, oxygen doesn't help these patients. Only for hypoxia, okay? Make sense? Right? And then we try to relieve the pulmonary edema, and how do we do that? We do that. Yeah, the diuretics, they work by increasing fluid loss, basically. They do help with venous distension a bit. They do help with venodilation, it seems. But they don't, the mainstay of treatment if they're quite sick is two things, which is nitroglycerin, which is afterload reduction. Because these patients, like I said, if you have extra fluids in your heart, extra fluid in your body, what your body does is you basically get increased vascular resistance, and that's going to worsen your diastolic heart failure. So the pulmonary edema happens because there's too much fluid in your body, and the blood will flow back into your lungs. So what we do is we try to lower the blood pressure if they're hypertensive. So lowering the blood pressure will help these patients a lot for their symptoms, acutely. How do we do that? We do that with nitroglycerin is the best drug we have there. You can use it as a patch or an infusion. Use it as sublingual also, spray. But mostly with thought we use it as an infusion because we can titrate it. So we try to drop the blood pressure, and then we give diuretics to decrease the fluid, but that takes time. That takes hours, to work. So and then what we'll also do is things like BiPAP. A BiPAP machine will decrease the afterflow, will actually drop the blood pressure the heart has to pump against, and will improve the perfusion of the heart. And will also improve the oxygenation because it provides oxygen and work with breathing. So the mainstay for thought for treating them is diuretics, nitroglycerin, or afterload reduction, blood pressure management, and BiPAP or plus minus oxygen, okay? And sometimes this doesn't work when the patient's very sick and they end up on a mechanical ventilator because they're too sick from their pulmonary edema, they're in respiratory failure, so we have to intubate them with a mechanical ventilator until this medication works. And then obviously treat the underlying cause. They have sepsis, treat the sepsis, they have a GI bleed, treat the CJ, they're having ischemia, they need to go to a cath lab, we need to fix the coronaries. Okay? Now the second type of acute heart failure presentation is hyperperfusion. These patients are the ones that come in with cardiogenic shock. Okay? So the heart acutely is not pumping well. And it's most commonly from ischemia. That's the most common reason. You have a STEMI, and then they come in with hypotension. Obviously, you're not going to try to drop their patient's blood pressure. That doesn't make sense. You're going to kill them by doing that. So these patients, the treatment is actually quite the opposite. You want to augment the cardiac output. So they need medication to improve the cardiac output. So generally, they'll be on inotropes, the medications, the IV medications to improve the cardiac output. And sometimes we'll even give them fluid because it can actually be intravascularly fluid depleted. Their fluids can actually be low. Actually, might give them some fluid to improve the cardiac output. But generally, these patients need emergent intervention. They often will need to go straight to the cath lab to reverse the cause, or cardiac surgery. It's a surgical cause, like a valvular rupture. They can come in like this, or a wall rupture, and they need cardiac surgery plus minus urgent recoronary perfusion. These patients will often die in the emergency department. Okay. So. The things to understand is, heart failure happens from pathological mechanisms, and the chronic treatments are just to basically mitigate progression of the disease. It's important to understand what the baseline disease of the patient, and then understand what the precipitant is, the stressor, because you want to treat that. That's what you want to treat primarily, to treat the precipitation. Most patients will come in with acute heart failure episodes or pulmonary edema symptoms are usually treated with just sitting them upright, some oxygen, vasodilators, and diuretics. That's the most common treatment you see for most of these patients. Plus, obviously, the underlying cause, which is mostly non-compliance, which is you're going to tell them go home and take your medication, right? If they come in hyperperfusion and heart failure and pulmonary edema, then it's usually cardiogenic shock. So these patients often will die, and they need inotropes, emergent cardiac surgery plus minus interventional cardiology. Make sense, Siobhan? Any questions about anything we talked about today?